Assalamu alaikum. Now today we're going to talk about the degenerative diseases and dementias. Dementia is actually development of memory impairment and other cognitive deficits. That means you have memory loss more often than usual people do, with preservation of a normal level of consciousness. So having memory loss doesn't mean necessarily that you're going to be unaware of your surroundings or you're not aware of the time and place you're in. You have normal level of consciousness, you just have memory impairment and other cognitive deficits we're going to be looking at throughout this video. Now, it's emerging as one of the most important public health problems, especially in the industrialized world. Why is that? Because in the industrialized world, we have a lot of people who are aging. As we can see, like there are a lot of people who reach 90s or their 80s, but here they're mostly like don't. And that's why the industrialized world has a medical and social and economic burden on them because of these dementias. Now, there are many causes of dementia, which we're going to talk about in a minute, but one thing we should really make sure to know is that dementia is not part of normal aging. It doesn't mean that as you grow up that you're definitely going to have Alzheimer's or other dementias, and always represents a pathologic process. So it's not a normal aging physiological process, it's always pathological. And some of them are sporadic and some are familial, and we're going to talk about them in just a moment. Now, the major causes of dementia, we have the primary neurodegenerative disorders. That means we have the disease is in the neuron itself. Like there's a degeneration of the neuron itself, and these are the most highly yield diseases in this chapter, which we're going to talk about in this video only about Alzheimer's, but later on you're going to see Huntington's, motor neuron diseases, and Parkinson's disease. Now, other not so high yield like diffuse Lewy body disease, PIC, which is al-Qarad, other frontotemporal degenerations, progressive supranuclear palsy, which is causes problems with walking, balance, and eye movements, but we're not so concerned of it right now. Now, for the now of course the primary neurodegenerative diseases, the doctor said that احفظوها زين 100% لأن عليها سؤال. Now, the infections, it's like prion-associated disorders like Creutzfeldt-Jakob disease, fatal familial insomnia, AIDS, PNL, like progressive multifocal leukoencephalopathy, viral infections like what happens in neurocephalus, which is, I think it's in the third stage of neurocephalus, and chronic meningitis. But those are not very important. Now, vascular and traumatic diseases, which we're going to talk about in a moment, like multi-infarct dementia, and other chronic vascular disorders like global hypoxic ischemic brain injury, of course, like when the blood flow to the brain is very largely decreased, that's going to affect the brain function and may cause dementia. Also, it could be caused by chronic subdural hematomas, and the doctor reminded us what's the cause of subdural hematomas. It's caused by rupture of a bridging vein. Now, for the other causes, we have metabolic and nutritional diseases like thiamine deficiency, which they call it Wernicke-Korsakoff syndrome. Now, this especially happens in alcoholics and those who actually drink a lot of alcohol. They have a problem, like they're addicted to alcohol. Vitamin B12 deficiency, especially for those who make gastric sleeve, endocrine diseases, and niacin deficiency, which they call it pellagra. Now, other miscellaneous disorders, like we have tumors, storage diseases of the neurons, toxic injury, like what happens in mercury, lead, manganese, and bromides. One example of mercury, like what happened in the fish in Japan, if you remember what happened. The diseases to be discussed in this section are only the degenerative, because we said they're the most highly yield. They're the, repeat after me, they're Alzheimer's, Huntington's, motor disease, and Parkinson's. But we should know, it's very important to know that not all forms of dementia is degenerative. So it's not always a primary neurodegenerative disorders, which is what we said, like a minute ago. We said that it could be like metabolic, it could be vascular or infections or tumors or any of the other reasons we said above. Now, vascular disorders, which we said we're going to talk about, like they're called the multi-infarct dementia. How does that happen? Now, this happens when patients suffer from for months or years. They develop dementia after they have multiple bilateral gray and white matter infarcts, which involves the centrum semi-ovale. Now, this is called vascular multi-infarct dementia when the pattern of injury preferentially involves larger areas. Now, this involves only smaller areas. When it involves only smaller areas, we call it vascular multi-infarct dementia. But when it's like progressively enlarges and involves larger areas of the subcortical white matter involving myelin and axon loss, this is what we call Binswanger disease. Like, imagine if someone has been like sleeping for too long, like for many years, and then woke up and he has larger areas of subcortical white matter and myelin and axon disorder. You say bonsoir and he doesn't say, so we call them Binswanger disease. I have no idea how that came up, but probably that's gonna make you like remember it. Okay, now to this picture. This is one of the pictures we talk in our general pathology course. Now, this involves a normal young adult brain. This is A, this is normal, and this involves atrophy of the brain. Now, as we remember, when atrophy of the brain occurs, it occurs when there is loss of the brain substance, like due to aging and reduced blood supply. The gyri are narrowed, and ergo the sulci are widened. So these hadid are becoming wider because the gyri are narrowed. This is just this is atrophy. It's not probably like not necessarily dementia. It's just atrophy. Now for Alzheimer's disease. If you ever watched The Notebook, you'd know what Alzheimer's disease is. The girl, or the old woman in it, was having Alzheimer's, where she didn't even remember her children. Now, Alzheimer's disease, it's one of the most common causes of dementia in the elderly. It becomes clinically apparent as insidious impairment of higher intellectual function, alterations in mood and behavior. So the early signs of Alzheimer's is higher intellectual functions, alterations in mood and behavior. The person becomes cranky or angry at times, but then like good at other times, and behavior is not like you look at them and you say, that's not you, you're not doing these stuff. Later, what happens is that progressive disorientation, memory loss, and aphasia. So the memory loss is not one of the first signs that you see in Alzheimer's patients. That's why early diagnosis can be done by clinical and radiologic methods, which we're going to talk about in just a moment. Now, as we said later, there happens progressive disorientation, memory loss, and aphasia, which is the inability to speak. These indicate severe cortical dysfunction because the cortical areas, they're responsible for these functions. And over the 5 to 10 years, like remember, like just imagine if someone can't even orientate themselves, they have memory loss, they can't even speak. Over the next 5 to 10 years, they're gonna be disabled, mute, and immobile. They're gonna be like, I'm worthless. I don't know anything. I don't even remember anything. Like that lady in Notebook, she doesn't even remember her own children. Now, death usually occurs from intercurrent infections, like those infections that occur in the same period of the progression of the disease. Now, Alzheimer's disease, now this is important, the incidence of Alzheimer's disease. It's 3% for those in their late 60s to early 70s, and 20% in those in their 70s to 80s, early 80s, and 50% in those 58 years or more. Now, the doctor said you can like تقربوها تخلوها 20% and this is 50%, but it's important to know that the incidence increases with age, and this is why it's a major medical, social, and economic problem in industrialized countries, because in these countries, as we said, المجتمع بيكون عندهم هرم, and the patients are actually like really elderly. Now, although pathologic examination of the brain tissue remains necessary for the definitive diagnosis of Alzheimer's, like just imagine if someone wants just to do diagnosis, they have to go through the whole brain tissue and actually do to have a definitive diagnosis of Alzheimer's. But this is of course not the case, because it would be costly, and nonetheless it would be like very dangerous for the patient if the surgeon was not good enough. So they replaced that by a combination of clinical assessment and radiologic methods like MRI or CT scans. Now, this allows accurate diagnosis in 80 to 90% of the cases, so there is no need to do a pathologic examination involving the brain tissue. It's only the accurate diagnosis occurs when the patient dies and we can open his brain freely and like نبحبش فيه. Now, most Alzheimer's cases, as we said, are sporadic, but we have like 5 to 10% of them are familial, and we're going to talk about this familial. Now, as we said, like Alzheimer patients, they rarely become symptomatic before the age of 50 years. This is for sporadic cases. They rarely have these early symptoms we talked about early before they're 50 years. But in the familial cases, since they're heritable, they can have the onset of symptoms earlier than the others. Now, how does the familial form of Alzheimer's disease occur? It occurs when there's accumulation of a peptide, which is called beta amyloid, or A-beta they call it, in the brain tissue, which initiates a chain of events. Now, let's see this picture here. Now, this is what happens in the accumulation of the peptide. Now, this is normal and this is abnormal. This is where it happens, Alzheimer's disease. Now, we have this protein, which is called amyloid precursor protein, which is normally found in the cell membrane. Now, we have the cleavage sites for alpha secretase and beta secretase. Now, when the alpha secretase works, this is gonna cause like a normal cleavage of the this protein. This is a soluble segment which can be gone out, and this is the segment which stays in here. This is alpha secretase cleavage. So alpha secretase is the one that should be working in normal conditions. But when it's not normal condition, like when there's beta secretase, it breaks it causes cleavage, which causes this A-beta peptide. Now this A-beta peptide, it's not soluble, so it aggregates and causes amyloid fibrils. So this is what happens in Alzheimer's disease. The beta secretase is the one responsible for all this dementia, because it causes the amyloid precursor protein to be cut in the wrong place, which causes A-beta peptides to aggregate and cause amyloid fibrils. Now back to the slides. This causes the morphologic changes of Alzheimer's disease and dementia, and as we know, this peptide is derived from a larger membrane protein. As we said, it's called amyloid precursor protein, which is processed in either of two ways, which we've previously mentioned. Now, Alzheimer's occurs in all patients with trisomy 21 Down syndrome. Why is that? We know Down syndrome people. Why is that? Because the gene encoding amyloid precursor protein is located on the chromosome 21, which causes this protein to be mutated. So it's definitely gonna happen. Like Alzheimer's is definitely like 100% it's gonna happen in all patients with Down syndrome who survive beyond 45 years. Because as we said, symptoms occur before 40 years of age for those with heritable forms. Nonetheless, that happens with Down syndrome, so it's definitely going to happen with them for those who survive beyond 45 years. Now, the accumulation of A beta has several effects. We have, as we said, those fibrils, amyloid fibrils, like what they're going to do. If they were small, they're going to cause altering in the neurotransmission, which can be toxic to neurons and synaptic endings. Now, this is not very degenerative, but it has some toxic effects. Now, larger deposits are the ones that actually cause Alzheimer's because they're really large and they are in the form of plaques. Now, these larger A beta deposits lead to neuronal death, which causes inflammation, and then cell injury, which causes altered region-to-region communication through mechanical effects of axons and dendrites. So there's definitely no communication between regions, and this causes the Alzheimer's. Now, grossly, let's see this picture right here. Now, Alzheimer's disease, this is a neurotic plaque. Actually, we were gonna talk about grossly. Okay, back to the slide. Grossly, the brain is small. Of course, it's atrophic. It's going to be less than 1 kilo after it was 1.5 kilos. It shows a variable degree of cortical atrophy. Of course, when there is atrophy, there is going to be widening of the sulci and narrowing of the gyri. It occurs in the frontal, temporal, and parietal lobes, which is very important to know and differentiate because there's a disease we're going to talk about in a minute that involves only the frontal and temporal lobes. After that, compensatory ventricular enlargement occurs because the brain tissue and brain parenchyma is atrophic. Now, how is it diagnosed? As we said, it's diagnosed histologically, clinically, and by the radiological methods. Histologically, how? By the presence of plaques. We can see those plaques in an extracellular lesion, but those neurofibrillary tangles, we can see them intracellularly. It's important to differentiate between them. So we can see plaques and neurofibrillary tangles, but both of them are not specific because we can see them in other diseases or in other non-demented individuals, like they have it but they don't have dementia or Alzheimer's disease, but of course they don't have it as much as those with Alzheimer's. Those with Alzheimer's are gonna have it much more than the normal individuals. So the current criteria for diagnosis is based on clinical and pathologic features, which we said the clinical, we're going to do some tests, like test their memory, their orientation, ask them for some important things like they're going to know about life, their memories, their short-term memories, their long-term, and all of those tests you can find online, or you can actually go to the doctor and ask them about it. And we have these pathologic features, like we said, we have plaques and the neurofibrillary tangles. But of course, it's hard to find them histologically because, as we said, we can't open the patient's brain when they're alive just to make a diagnosis. So they make it clinically and radiologically by the MRI or CT scans. Now, there's fairly constant pattern of progression of involvement of brain regions. So we have the pathologic changes. Pathologic changes, they specifically they involve the plaques, tangles, and the associated neuronal loss and glial reaction. Now, these are especially high yield in the matter of Alzheimer's disease. So when we see them, we definitely think of Alzheimer's. Those are evident earliest in the entorhinal cortex, then spread to the hippocampal formation, isocortex, and then to the neocortex. Doctor didn't actually ركز كتير عليهم, but I don't know if they're important or not, but you're gonna have to memorize them. Now, silver staining or immunohistochemistry, those are extremely helpful in assessing the true burden of these changes in a brain because, as we said, immunohistochemistry is what allows us to see like those plaques and neurofibrillary tangles, which are like 90% sure that it's Alzheimer's. Now, these neurotic plaques, they can be 20 to 200 micrometers in diameter with microglial cells and reactive astrocytes. Let's see a picture of them. Now, here we see this is a neurotic plaque. Now, we should know like what are its constituents. Now, this neural plaque, it's formed by a core and a periphery. As we see, the core is different from the periphery. Now, the core, it's actually the aggregation of those beta amyloid aggregates. So the core actually contains those aggregates, central area of amyloid deposits, and in the periphery we have those dystrophic neurites, which are almost black in color. Why? Because we've used the silver staining, and the silver staining, like they تشربوا هاي silver staining, so they become almost black. And this is how the neurotic plaque is actually looking like. So a neurotic plaque is focal spherical collections of dilated tortuous silver staining dystrophic neurites and tangles, which are filamentous intracellular inclusions. As we said, filamentous and intracellular inclusions. The plaques are intracellularly surrounding by a central amyloid core. They are surrounding a central amyloid core 2 to 200 micrometers in diameters. Now, as the doctor said that the bigger it is, the more severe the disease is. Like, just imagine if it's bigger, that means like there's more neuronal death and more cell injury, and this means like there's less communication between cortical areas, and this means more dementia. Now, in this picture, we can see like the immunohistochemistry against the beta amyloid. It shows that the peptide is present in the core of the neurotic plaques. The peptide, beta amyloid, and in the surrounding region. So it's found in the core and in the surrounding region. Here we can see the tangles of tau. Like we said, we have these neurofibrillary tangles, those tau tangles, neurons containing tangles. So it's important to see that these tangles of tau are intracellularly. They're not outside of the cell, they're inside the neuron. And as we said, we use the immunohistochemistry stain for this tau protein. Now back to here. We said that these neurotic plaques, they have a central amyloid core, which contains the accumulation of this peptide beta amyloid, and surrounded by the dystrophic neurites, which are gyrophilic. Gyrophilic means they إنهم شربوا صبغة الفضة اللي هي silver staining. That's why they are like almost black in color, present at their periphery. Now these plaques, you can see them anywhere from the hippocampus, the amygdala, neurocortex, but if you see them in the primary motor cortex or sensory cortices, then you can know that this is a later stage of the disease. Now these A-beta deposits, they can be found without these peripheries, like without the dystrophic neurites, and like انت بس بتشوف الكور لحالها اللي هي the beta amyloid core, and this core, this is what they call diffuse plaques. Now these diffuse plaques, you can see them typically in the spherical portions of the cerebral, in the superficial portions of the cerebral cortex, as well as the basal ganglia, cerebellar cortex. They also may be actually present as an early stage of plaque development. Since we only see the core, then the periphery can be created later. So it can be like an early stage of plaque development of Alzheimer's disease or other diseases that have these neurotic plaques. We didn't see this picture. Now, Alzheimer's disease, this is a biopsy from a man who died from God knows what. The man was 63 years old, stained by periodic acid silver method. So we use the silver acidic method or stain for the Alzheimer's immunohistochemistry. Now, subarachnoid space and cortex, they're at top. So this is like من برا لجوا, right? Yeah, subarachnoid space with cortex are at top. And here in the brain parenchyma, we can see the neurotic plaques. This is a neurotic plaque, and this is another 1, 2, 3, 4, 5, 6, 7, like a lot of them. Those are dark and rounded, consisting of a central amyloid core. As we said, the core contains accumulation of beta amyloid, and the periphery contains these dystrophic neurites. Now, this is not very seen. This is not very like obvious like this one. This one is, I guess it's higher magnification that you can see the core and the dystrophic neurites around it in the periphery. But this one, it's lesser magnification. Yeah, it's less. This has the neurotic plaques, like we can see the cores and the periphery, but they're not very differentiated in here. And small blood vessels stained red thick are seen in here. So this is Alzheimer's disease. Now the neurofibrillary tangles, as we said, those are from the tau protein. Those are bundles of paired helical filaments. We can see them intracellularly. They can displace or encircle the nucleus. Now, tangles can remain after neurons die, so these tangles can actually become extracellularly. Since the neurons die and they were inside them, the neurons degenerate and they can go outside of the cell and become an extracellular pathology. Now, this is a very progressive late stage of the Alzheimer's disease. Where they're commonly found? They're commonly found in the cortical neurons, especially the interhinal cortex, pyramidal cells of the hippocampus, amygdala, basal forebrain, and Raphi nuclei. Like, you can see them anywhere. But the common places are these. One important thing to know is that the major component of paired helical filaments is this abnormally hyperphosphorylated forms of the protein tau. And this protein is the one responsible for these tangles. Now, we should know also that neither the neurotic plaques nor the neurofibrillary tangles are specific for Alzheimer's disease. They can be found in other degenerative diseases as well, like we're going to see in just a moment in the frontotemporal dementia, as well as in normal individuals. Now, let's see the frontotemporal dementia. This is another category of dementias. It occurs in mutations in the gene encoding tau. So there's a mutation in this gene, so it's going to accumulate, causing those neurofibrillary tangles. Now, the protein found it shares clinical features with Alzheimer's disease, like progressive deterioration of language and changes in personality, like the person changes in behavior and cannot actually speak properly. He has aphasia. Corresponding to degeneration and atrophy of the temporal and frontal lobes. From its name, we can actually conclude that it's only of the frontal and temporal lobes, unlike Alzheimer's, which also involves the parietal lobe. Now, the symptoms often occur before memory disturbance, and this is how we make a differential diagnosis between it and Alzheimer's. Like if the patient comes first having problems with speaking, having problems with language and changes in personality, we can say that it's frontotemporal dementia. But if the patient comes first having problems with remembering and وبيكون في عنده خلل بالذاكرة, so it's probably Alzheimer's. But we have like other things to do. It's not like guessing and then giving the drugs. So we have like the clinical and pathological and the radiological, like the MRI and CT scans to to have an accurate diagnosis. But mostly, like من وجهة نظر أكاديمية, as the doctor said, you can say that we can have differential diagnosis according to the first symptoms that the patient first comes up with. Now, grossly, the basic finding is that the frontal and temporal lobes are atrophic. Other things like we have abnormal accumulations of the tau protein. As we said, we have neurofibrillary tangles, not just in Alzheimer's disease. We can have them in other diseases like this frontotemporal dementia. And that's it. And thank you.